and welcome everybody to this webinar on the Millon Adolescent Clinical Inventory, and I will refer to this as the MACI going forward. This webinar will focus on both a select and a unique group of individuals, the group of adolescents who are struggling with clinical issues. Those of us who have worked with adolescents, and I worked with adolescents in high school as well as in private practice, those of us who've worked with adolescents know that some of them can face unique challenges at that stage of life. You may think about peer pressure, think about family dynamics, maybe substance abuse, maybe suicidal ideation, suicidal tendencies. We also know that adolescents are really quite adept at masking underlying problems, right? So when you think maybe of the sullen gaze of the adolescent who was referred to you by his teachers, what about the blank stare that the adolescent gives you in response to some of your questions? Maybe the practiced smile. The information from the MACI can assist us in developing customized treatment plans that will help us to guide troubled youth toward healthier lives. So before I get started with the content of our presentation, if you would let me know whether or not you have used the MACI. So have you used the MACI? If you would select either yes or no and then click submit to see the results. Okay, the results are coming in here. Thank you so much for your responses. It looks like we're going to have about an even breakdown with slightly more of us having used the MACI than not. So our presentation today is going to be an overview of the MACI. And those of you who've used the tool in the past, you'll recognize some of the concepts. Hopefully some of the concepts will reinforce the way that you've used the MACI in your practice. And for those of you who've yet to use the MACI, we hope that you'll find the content useful. So what we hope to accomplish within the next 50 minutes or so, we want to start by describing the features of the MACI, and then I want to talk specifically about the personality pattern scales. I'll talk about several different types or different categories of scales on the MACI, but we want to spend some time looking at the personality pattern scales, especially in relation to Dr. Millon's evolutionary theory. And then finally, toward the end, I want to apply some of the concepts that we described when we were looking at the features and when we talked about the personality patterns. I want to use those concepts to interpret a sample MACI profile. So I want to get started by thinking about the features of the MACI. And I hope that most of you have received the handout that includes most of the slides I'm showing here today. We distributed the handout along with the reminder email that we sent yesterday. So what is the MACI? First of all, the MACI is an objective self-report inventory. It consists of 160 items to which the adolescent will respond either true or false. And the tool was designed to be used in settings where we are likely, we as psychologists, as maybe family therapists or maybe other mental health professionals are likely to encounter adolescents who are experiencing some struggles. So you're thinking about maybe clinical settings, residential settings, possibly correctional settings. When you think about the MACI will be used for evaluation, diagnosis, and I mentioned before that the data are really helpful when we think about treatment planning. So the MACI will provide us with information about an adolescent, about the adolescent's possibly expressed concerns, any concerns that the adolescent is experiencing. Maybe you're thinking about peer conflict or feelings of inadequacy. We'll also be able to get information about clinical syndromes, think maybe about depressive affect or maybe anxious tendencies. And we'll also get information about the adolescent's personality patterns, thinking maybe about severe introversion or maybe delinquent propensities. So we'll talk more about the expressed concern scales, the clinical syndrome scales, and the personality pattern scales. Now, I mentioned before that the MACI is used in settings where we are likely to encounter troubled teens. It's important for you to know that the norms for the MACI, well, first of all, that the focus of the MACI is on clinical concerns, and the MACI is used in clinical settings. So the norms were established on clinical samples of adolescents, teenagers, ages 13 to 19 years. So if you are working with an adolescent or teenager and you do not suspect psychopathology, you'll want to consider other instruments besides the MACI. So I want to spend a few minutes looking at the scales that are offered with the MACI. I mentioned these scales before, expressed concerns. There are 8 scales that assess expressed concerns, 7 that assess clinical syndromes, and 12 that assess personality patterns. I'll talk about each group of scales here in a minute. But in addition to these scales, because this is a self-report inventory, it's important for us to be able to assess the validity of the profile, and a number of modifying indices are included on the MACI that will allow us to determine whether or not the profile, the resulting profile, is valid. So let me just start by saying a few words about the expressed concerns scales. The expressed concern scales, I mentioned there are 8, pretty much focus on feelings and attitudes that tend to concern troubled teenagers. So troubled teenagers may be unsure of their identity, or if they are sure of who they are, they may be dissatisfied with their self-image. They may disapprove of their body. They may be confused about sexual thoughts and feelings. There might be some insecurity related to peer relationships. They may lack empathy. Maybe there is some conflict and tension within the family, and some may have experienced verbal, physical, or sexual abuse. When you look at these scales, you're thinking about the perceptions of the adolescent with respect to these specific scales. Now, for each of these groupings of scales, you'll notice that there is maybe an alpha coefficient that is used to report the internal consistency of the scales. And this would provide an indication of how well the items included on the scale represent the same underlying dimension. Certainly when we look at self-devaluation, the alpha coefficient of 0.91, and then a number of these that are in the 80s and several that are in the 70s. Certainly you would describe the internal consistency of each scale as acceptable to good, and the median value falling at around 0.79. Similarly, when you look at the clinical syndrome scales, these 7 scales assess symptoms that tend to cluster together into well-defined clinical syndromes. For example, anxiety and depression, but also suicidal tendency, eating dysfunction. Certainly substance abuse is an area of concern when you think about adolescents and teenagers. And then what about delinquent predispositions and impulsive propensities? Again, when you look at the internal consistency of the scales, you'll notice that the alpha coefficients are acceptable to good. Now, one of the things that I want to say about the clinical syndromes really is that these clinical syndromes, or any clinical syndromes that I would endorse, are best conceptualized as extensions or distortions of the person's basic personality. So the clinical syndromes tend to accentuate the teenager's basic personality style. So I want to say a few words now about the personality pattern or personality styles. And again, when you think about the clinical syndromes, think about how the clinical syndromes could extend or distort the basic personality pattern. I mentioned that there are 12 personality patterns scales on the MACI. And if some of you are familiar with the Millon inventories that we use for adults, the MCMI-4, for example, you'll recognize some of these parallel DSM disorder names. On the MACI, we have 12 what we call personality patterns scales. And those are numbered, and you'll notice the label for each personality pattern: introversive, scale 1, doleful, scale 2B, egotistic, scale 5, for example, self-demeaning, scale 8B. And again, you'll notice that the parallel DSM disorder, or the ones that we'll recognize if we're familiar with the adult version, or if we work with the diagnostic and statistical manual. Inhibited, the parallel DSM disorder, avoidant, submissive, parallel DSM disorder, dependent, egotistic, narcissistic, and so on. Again, when you look at the internal consistency, you'll notice that these scales are internally consistent with coefficients mostly in the good range and the submissive in the 70s. Now, we spend much more time talking about the personality patterns or personality disorders if you were thinking about the adult version of Dr. Millon's assessment instruments. And the reason for that is that personality patterns play a central role in mental wellness. So Dr. Millon describes the role of personality in mental wellness. And if you think about an adolescent who might be experiencing clinical syndromes such as depressive affect, anxious feelings, maybe they're experiencing some psychosocial stressors. I mentioned the family discord. Dr. Millon's contention is that the personality is the key to the adolescent's psychological well-being. So the construct personality, if you think about it, it is like the mind's equivalent of the body's immune system, right? So my personality will maybe immunize me against some of those clinical syndromes or maybe some of those expressed concerns. How I respond to those psychosocial issues, to those clinical syndromes, will depend on my personality pattern. So my personality will represent my capacity to cope with my psychosocial world. So the personality patterns, or for the adult versions, the personality disorders, really are the important psychological immunizing factors if you want to think about it that way. Because of that, I want to spend just a few minutes thinking about how Dr. Millon developed the personality patterns on the MACI. So these personality patterns were developed based on Dr. Millon's evolutionary theory And each of the 12 personality patterns is also described in terms of clinical features that fall into functional and structural domains of personality. So I want to consider the personality patterns first in relation to Dr. Millon's evolutionary theory. So Dr. Millon's study of personality, and I should mention that the MACI was initially published in 1993, and then we added some additional concepts in about 2006. So Dr. Millon's evolutionary theory is described in several of his writings dating back to 1969. And toward the end of your handout, you'll find some references to Dr. Millon's writings as they pertain to evolutionary theory. So his study of personality began with certain universal principles, the universal principles of evolution. And scientific principles that were grounded in, like, Darwin's laws of nature pretty much served as the guiding framework for understanding personology, understanding how we differ as individuals. I want to start by thinking first about how we conceptualize personality patterns, especially when you think about adolescents. Now, one of the things that I forgot to point out when I was showing you the 12 personality pattern scales and the parallel DSM disorder labels, you noticed, I'm sure, that the labels for the MACI personality patterns are not as pathological as the labels for the DSM disorders. And that is because the personalities of adolescents are developing and they are not as stable as the personalities of adults. So if you think about personality patterns, especially as they pertain to adolescents and teenagers, think about these as the strategies that we learn that will secure for us positive reinforcement and minimize punishment. So what if you're working with an adolescent who has learned through his or her familial experiences that pleasing his father, say, was the way to secure positive reinforcement? Maybe another adolescent has learned that passive-aggressive behavior was the way to get his or her needs met. If you think about these considerations and keep those in mind, because what I want to do now is consider how Dr. Millon used evolutionary principles to define different personality patterns. So if you think about evolution, you think about 4 domains in which evolutionary principles are demonstrated. And 3 of those 4 are captured here: existence, adaptation, and replication, and the 4th is abstraction. Now, the first 3 of the 4 domains, existence, adaptation, and replication, are expressed in polarities, and they provide the essential elements of Dr. Millon's theory. And what Dr. Millon did is he used these domains to construct a theoretically embedded classification system of personality patterns. So think about it. If you construe personality patterns as learned strategies, as we defined a minute ago, they're learned strategies to secure positive reinforcement and to minimize punishment. This polarity, the existence polarity, the existence domain, which has 2 polarities, pleasure and pain, the pleasure-pain polarity represents the nature of the response that I elicit from others. And this response can be either positive or negative. Now, down here, the adaptation domain is presented in terms of two polarities, passive and active. And the active-passive polarity represents the behavior that I will use to maximize my rewards and to minimize my pain. Now, active personalities will typically take the initiative. They interact with their environment to achieve gratification, to avoid distress. Passive personalities are more reserved. They tend to maintain a more accommodating stance with respect to the environment. And then down at the bottom, the self-other polarity, under replication, the self-other polarity represents the source to which the person will turn to enhance his or her life and to gain satisfaction and avoid pain and discomfort. Those who look to themselves are termed independent on the self-other polarity, and those who look to others are termed dependent on the self-other polarity. Now, how does this work? How do these polarities work in terms of developing the personality patterns? Well, first is that we want to think about what a healthy personality looks like. When you think about healthy, well-adjusted, adaptive individuals, they're individuals who demonstrate reasonable balance and flexibility across the three bipolarities, right? They're capable of both active and passive adaptation. They're mildly motivated toward pleasure, away from pain, and they can be gratified by both themselves and by others. On the other hand, when you think about maladaptive personalities, the individuals or the adolescents or teenagers who might come to see us in our offices, they are individuals who show imbalances or conflicts on the polarities. Some might be overly passive, some might be overly active, some might be strongly motivated to avoid pain but not seek pleasure, some might rely more on the self, some might rely more on the other. So Dr. Millon took these bipolarities, combined the polarities to derive personality pattern scales that parallel many of the personality disorders recognized by the DSM. And of course, if you think about the date of publication, the year of publication, you could think about the DSM edition that was in place at the time. So here is where I want to spend a few minutes, because I think when we look at the evolutionary model and personality patterns, and we think about those three domains in terms of their polarities, we really understand how an individual might be struggling, and we also understand the best approach may be to helping that individual, to move the individual more toward that homeostasis or that balance on the polarities. So let me start by thinking a little bit about the pleasure-pain polarity. So here I have the pleasure-pain polarity. I have the self-other polarity, and then down here I have passive and active. So when you think about those 12 personality patterns, and I have them listed here, you will notice that the central feature of these personality patterns, introversive, doleful, inhibited, self-demeaning, and forceful, is this pleasure-pain polarity. So the central feature for the introversive, the doleful, the inhibited, the self-demeaning, and the forceful personality patterns is that pleasure-pain polarity. Now, you can tease this out even further, and this is what you do when you are interpreting an individual's profile. When we look here, for example, you think about the introversive, the doleful, and the inhibited. Those are individuals where the introversive focuses little on pleasure, focuses little on pain. The doleful focuses more on pain, less on pleasure. Inhibited, more on pain than on pleasure. So the commonalities among the introversive, doleful, and inhibited personality patterns is the inability to experience pleasure. Neither of those three personality types experiences pleasure, but for different reasons. The individuals with the introversive and doleful personality pattern, they function as passive observers, right? The introversive is detached from rewards and affections. The doleful personality, on the other hand, experiences pain as permanent. They believe that pleasure is no longer possible. For the inhibited, in contrast, notice that this is an active orientation. The inhibited, there is this hyper-alertness to anticipated pain. I am so focused on the pain that I absolutely know is coming that I cannot pay attention to joy. So the obsessive focus on pain prevents me from being able to focus on joy. So they actively seek, and this is the active component, they actively seek to avoid the anticipation of pain. Now, there are some adolescents for whom the usual properties associated with pain and pleasure are conflicted. Notice here the pleasure-pain reversal. If you think about this self-demeaning personality pattern, that pattern largely stems from a reversal of the pleasure-pain polarity. This is a person for whom pain has become preferable to pleasure. Now, they passively accept pain and sometimes may even encourage pain in intimate relationships. When you think about the forceful personality, which also is characterized by that pleasure-pain reversal, this is an individual who assumes an active role when you think about controlling, dominating, and maybe intimidating others. Now, if you look at some of these other patterns and you think about the self-other polarity, there are several personality patterns that are characterized by either maybe a reversal, a focus on maybe either the other at the exclusion of the focus on the self. You'd say this would be the focus on the other is high versus over here the focus on the self is high. You're thinking about that dependent and independent polarity that I described earlier. So when you think about the self-other polarity, think about individuals whose difficulties might stem from their focus on themselves or maybe their focus on others. The submissive and the dramatizing personalities tend to focus more on the other and in terms of getting their needs met, whereas the egotistic and unruly personality patterns tend to focus more on the self. Egotistic, if you think about the DSM, the narcissistic, this would be somebody whose focus is primarily on the self. But you might also have, on the self-other polarity, you might also have ambivalence or discordance where the person is not entirely clear whether they focus on self or other. And depending on the situation, they might focus on self or on the other. So there is this intense conflict between the self-focus and the other focus. And the last thing I want to tell you about these is the last one down here, which is the borderline tendency. the borderline tendency scale, just like borderline on the MCMI-4, is set apart from the other personality pattern scales to reflect its greater severity. So the borderline personality, the borderline tendency pattern really corresponds to the theory's ambivalent orientation and ambivalent on these three polarities. So you're thinking about conflicts existing on between pleasure and pain, between active and passive, and between self and other. So think about the evolutionary model and how these three polarities actually led to the conceptualization of these personality patterns. But in addition to the evolutionary theory, it was also important for Dr. Millon to think about the clinical features of the personality patterns. So after he derived the personality scales, he looked at the clinical domains that would characterize each personality pattern. And the eight components, or the 8 clinical features, are grouped either in functional domains or in structural domains. So theoretically, each personality is expressed through 8 domains. 4 of these domains, expressive behavior, interpersonal conduct, cognitive style, and regulatory mechanisms, are described as functional domains. And they're called functional because they really represent modes of regulatory action, so things that we do. The remaining 4 domains are considered structural domains. They are self-image, object representations, morphologic organization, and mood and temperament. And these are relatively permanent or semi-permanent characteristics, and for that reason, they are described as structural. Now, another way that we can classify these domains of personality is according to the data levels that they represent. And if you look at these data levels, you will see the evolution of the field of psychology, because if you think, for example, down here at the bottom, mood and temperament under the structural domains actually falls under the biophysical model, and the biophysical approach to thinking about maybe treatment and approaches to therapy, for example. If you think about the biophysical models, think maybe about the individual's biophysical models. Think about mood and temperament as related to the biophysical model. Regulatory mechanisms and morphologic organization relate to the intrapsychic model, or associated with the intrapsychic model, which includes maybe some of the models, for example, started by Dr. Sigmund Freud, models that study the unconscious in different ways. And then when you think about cognitive style, self-image, and object representations, we're thinking about phenomenological approaches, maybe such as those proposed by Rogers and Maslow, but also cognitive theories such as those by Beck and Ellis. And then finally, expressive behavior and interpersonal conduct are associated with behavioral models. So here is the importance of this. When you think about my personality pattern, and you think maybe that my personality pattern is characterized primarily by elevations in expressive behavior and interpersonal conduct, think about what that might tell you in terms of the treatment approach that might be effective possibly when you are working with me and trying to help me to reestablish some homeostasis. So again, think about these functional and structural domains as the clinical features that really help us to describe the personality pattern, but also that would help us to consider possible treatment approaches. Now, if we think about the 12 personality patterns and the 4 functional domains and 4 structural domains, you can create a matrix that would actually help you to present the clinical features of each of these personality patterns. And so, for example, if you're thinking about the doleful personality pattern, the expressive behavior is one of the most salient clinical features of the doleful personality pattern. Specifically, the doleful personality's expressive behavior is described as disconsolate. Cognitive style is another feature that is salient. According to Dr. Millon, when you think about these 8 features, you're thinking about maybe 3 of them as really being the most salient. Some of them will be of moderate or supportive importance, but we want to be able to identify for each individual the clinical features that will be elevated when we look at the individual's profile based on his or her responses. So the individual's cognitive style for the doleful personality would be described as pessimistic, and mood and temperament would be described as woeful. If you think about maybe oppositional, certainly expressive behavior is an important clinical feature as well. The individual is often resentful, interpersonal conduct is contrary, self-image discontented. You notice I have some of these presented here in red. And the reason for that is that the ones in red are the 3 that are considered to be the most salient for that personality pattern. And those are described in the manual as the Grossman Facet Scales. So if you think about the Grossman Facet Scales, and you think, for example, maybe about scale 6B, forceful, this would be an individual who might be described as interpersonally abrasive, expressively precipitate, maybe isolation mechanism. So whether or not these are actually the clinical features that apply to the individual with whom you're working will depend on the elevation on that particular facet scale. So when I show you the sample profile, you will see that there are certain scales that may or may not be elevated, even though those facets are considered to be clinically relevant to that particular personality pattern. So I've talked so far about the expressed concern scales, I've talked about the clinical syndrome scales, and I've talked about the personality pattern scales. I also mentioned that the MACI includes a number of modifying indices, 4 modifying indices: disclosure, desirability, debasement, and reliability. And I think the scales are consistent with scales that we find on other objective measures of personality. So when you think about the disclosure scale, thinking about the degree to which the adolescent was willing to be open, honest, and self-revealing. The raw score for this one is a weighted combination of the raw scores on scales 1 through 8B, so it's not based on a set number of items. Desirability assesses the extent to which the results may have been affected by the patient's inclination to appear socially attractive, to respond in the desired direction. And debasement measures the opposite, whether or not the individual was likely to devalue or deprecate him or herself. And then reliability, finally, includes 2 items that are highly improbable and pretty much will reflect how well the respondent was paying attention as he or she was completing that self-report. And on this one, if you have a raw score of 2 on the reliability index, the the test should be considered invalid. Most people will not respond in the scored direction to the 2 items on the reliability scale. So when you think about the administration, scoring, and the interpretation, I want to say a few words about administration and scoring first. The MACI can be administered either in English or in Spanish, and you can use paper and pencil. And if you use paper and pencil, it can be scored either by computer or by hand. And the test can also be administered and scored by computer. And if you're working with a client or a patient who might have visual handicaps or whose reading skills might be limited, and the items on the MACI are designed to be accessible by individuals with about a 6th grade reading level, but if they're not, if the reading level is lower, there is an audio recording available that you can use to present the items. In terms of scoring, you can score the MACI using Pearson's web-based scoring system, the Q Global platform. It can also be scored at your site using Q Local, or you can also access computer scoring by mailing in your adolescent's answer sheet. If you choose computer scoring, you can generate either an interpretive report or a profile report, and the difference is that the interpretive report will include a narrative description of the test results. Or you can use the tables in the manual to hand score. Okay. Now, when we look at the profile, I will be talking about base rate scores. The type of score that is used to understand the results of the MACI, just like the MCMI-4 and other Millon inventories, is a base rate. So the base rate, unlike a T-score, base rates are established using prevalence rates of each personality pattern. And the base rates are derived based on raw score frequency distributions. We identified certain anchor points, 115, 85, and 75, and essentially any base rate of 85 and above would tell us that that personality pattern is perhaps the most prominent. If you think about base rates greater than 75, we would interpret that base rate to mean that the personality pattern is either present or possibly prominent. So we'll use the base rates to gauge both the presence of a personality pattern and also to give us some idea about the severity of the personality pattern as well as the clinical syndromes. So if you think about the base rate in terms of interpretations, 85 and above will tell you that that personality pattern is present and it likely impairs the adolescent's functioning in his or her day-to-day environment. Think about 75 to 84. Some likely psychopathology is present, maybe at the trait level. And then a base rate between 60 and 74, maybe some features of that personality pattern. Okay, so I want to get to the interpretation here using that case study, and we want to leave a few minutes for questions towards the end. So when you think about the interpretation of the MACI, and those of you who've used the MACI, you're familiar with this interpretive model. But even if you have yet to use the MACI, this is a model, I think, that we use in psychology when we're thinking about personality assessments. We begin by reviewing the patient information. What do we know about clinical features with respect to the patient? What about observations and interviews? What data do we have from those? What about other test results? When we review any of the referral information, for example, what about demographic characteristics such as background, gender, age, and so on? And then we want to make sure that the profile is valid. So we want to analyze the modifying indices. And then we want to look at the sections of the profile. And we want to begin our analysis by looking at the personality patterns. You'll remember that the personality will serve as the psychological immunizer, if you will. So when we look at personality pattern scales, think about the configuration of the scales. In terms of the elevations, do you see a certain pattern? And then what about the Facet scales? If there are elevations on the personality pattern scales, which of the clinical features would actually explain the elevations on the scale? And then what about expressed concerns? Again, looking at the elevations, looking at any patterns, and then the clinical syndromes. And then finally, you want to integrate the profile, thinking about expressed concerns, clinical syndromes, and personality patterns, the integration of all of the information that you have. So I want to talk about this young lady, and I want to use the profile, her profile of the MACI, to hopefully bring to life some of the concepts that we introduced theoretically. So when you think about this young lady, her name is Samantha, and she's 16 years old, and she is in 10th grade. So just to tell you a little bit in reviewing the information that we have about Samantha, let me just tell you a little bit about her. Her parents divorced about 3 years ago, and Sam, when you think about expressed concerns, she feels maybe that she might have disappointed both of her parents, maybe both as a daughter and as a student. And she actually believes that this might have led to her mother's decision to ask for a divorce. But overtly, what we see is that she blames her mother for the divorce. She defies the curfew that her mother has set for her. She refuses to complete the chores that her mother assigns. She's had numerous arguments with her mother about staying out late, not coming home, being sexually active, failing classes. And her defiance has caused a great deal of anguish for her mother. And this is perhaps important. This anguish that her mother is experiencing seems to please Samantha. Now, she recently started dating a young man who is 3 years older than she is. He's a high school dropout, and she reports that she likes the excitement of his lifestyle, which includes selling drugs. She herself has used drugs such as crystal meth and marijuana on occasion. She's also used alcohol, especially when she's with her boyfriend and his group of friends. She's received 2 speeding tickets, after which she had her car taken away by her parents. She was arrested for driving under the influence, but her dad, who's an attorney, was able to void any of the legal consequences. So because of her erratic behavior, her parents are actually considering sending her to finish high school in a distant state. And before they do that, of course, Sam is not amenable to this. Before they do that, they've decided to have her evaluated by a psychologist before making further decisions about her schooling. And the psychologist decided to use the MACI among the assessment tools that she chose. So I want to start by looking first at the validity of the profile. Look at the modifying indices first. Is this a valid profile? Notice the reliability score is 0. If the raw score on the reliability score was 2, this profile would be invalid, but the reliability score here is 0. And also you'll notice that she tended to respond in the direction of desirability, so high self-revealing inclinations, self-enhancing the high self-revealing inclinations are here under disclosure, but the self-enhancing response tendencies, if you look at the base rate over here, 95, certainly higher than that 85. So when you have scores that look like this or a pattern that looks like this, it's important sometimes to think about adjusting the scores for several of the personality pattern scales. When the computer does the scoring, the adjustment is done automatically. So this is a valid profile, and now we'll look at the personality pattern scales. Again, look at your base rate scores. You can also look at the profiles. Notice 85 over here. I look at the base rates, 85 for the oppositional scale. The next highest is a base rate of 80 for the forceful scale. The next highest is a base rate of 76 for the unruly scale, and then 73 for the dramatizing scale. So here's the important thing. Even though I could conceivably say, well, in terms of the configuration here, maybe I would think about describing her personality pattern as oppositional and forceful personality traits, maybe with unruly and dramatizing features. We recognize, working with objective personality instruments, that even though traits and features of personality disorders are observable, and certainly observable here for Samantha, we do not want to use the data from the MACI to assign diagnostic labels unless we have additional clinical information. And even when we assign a diagnostic label to an adolescent, we understand that these diagnostic labels tend to be less stable for adolescents than they are for adults. But certainly you could think about these elevations. This would be the configuration, oppositional and forceful, with unruly and dramatizing personality features. And then you want to take a look at the Facet scores. I always find the Facet scores really helpful because they get me to start thinking about treatment approaches that might be effective. So when I look at those three highest scores, the oppositional scale 8A, the base rate was 85, 6B, forceful, base rate of 80, 6A, unruly, base rate of 76. When I look at the Facet scales that are elevated for each of these elevated personality pattern scales, what I notice is that the clinical features tend to cluster along two different parts of maybe the functional domains, right? When you think about those clinical features, the functional and structural domains, they have to do with the expressive behavior, and they have to do with the interpersonal conduct. So when I look here at the elevations in terms of the base rates, certainly expressive behavior, interpersonal conduct. Expressive behavior, interpersonal conduct are the ones that are elevated here. Again, down here, when you look at unruly, expressive behavior is elevated. So for Samantha, you're really thinking in terms of evolutionary theory about that self-other polarity. And in terms of the functional and structural domains, you're thinking about the expressive behavior and the interpersonal conduct. So what do we know? She's expressively precipitate, right? Right here. She reacts in sudden, abrupt, unexpected outbursts. She's expressively impulsive. She acts hastily, spontaneously, in a spur-of-the-moment manner. She's careless. If you look at the interpersonally up here, she's interpersonally contrary. She's obstructive, intolerant of others. And then you do the same thing if you look at the expressive behavior, at the interpersonal behavior, right? So you look at the interpersonal behavior, interpersonally contrary, she's interpersonally abrasive. So what do those descriptors tell you in terms of describing her thoughts, feelings and her behavior. And also consider that both the expressive actions and the interpersonal conduct are both related to that behavioral approach when you think about the functional and structural domains and those levels, and think about what that tells you in terms of appropriate treatment approaches. When you look at the expressed concerns, notice that probably some serious family problems might complicate the other difficulties that she is experiencing, and then also the social insensitivity, which we actually identified previously when we looked at the personality patterns. And then when you look at the clinical syndromes, notice the ones that are elevated here. Certainly the impulsive propensity. Again, we identified that under the Grossman Facet scales. And then the 83, delinquent predisposition. 82, the substance abuse proneness. We identified that based on the intake information. We know that she's used drugs as well as alcohol. And then notice here the 80 for depressive affect. So essentially, when you integrate this picture, what you're thinking is, how can we help her to function more effectively? So think about the therapeutic implications based on the integration of the data from those different sources. Certainly, we want to be able to rule out this acute alcohol or drug abuse problem, or maybe to confirm it. And if we verify, we want to make sure that we use appropriate behavior management or group therapeutic programs. You also want to think about some directive cognitive techniques. Think about the expressive behaviors on which we'd like to focus, as well as the, thank you. We do have online training available, and you can earn up to 3 APA CE credits for that, and the access information is here. Okay. So were there any questions that Dr. Tringone can answer for us, Vandita?
Thank you, Dr. Maccow, for the really informative presentation. We did have a couple of questions come up. So one attendee has started working with adolescents again recently, and she gave the MACI to a teenager who is diagnosed with autism spectrum disorder. So she was wondering if we can point her to any articles that talk about ASD and MACI. So Dr. Tringone, do you have any suggestions that, or any articles that you can point them to?
Okay. I hope everyone can hear me. Appreciate that question. And I would say that I am not aware of any specific articles looking at autistic spectrum disorder with the MACI, but I would say that if somebody was a little more high functioning along that spectrum, that the most likely scale elevations that you will find are to be on the peer insecurity scale and potentially the inhibited scale. But it is, in its own way, a heterogeneous group, so that there's nothing specific that I think is going to come out that would say to someone administering the MACI with this type of teen that this profile is going to say, yeah, this is what I'm thinking, and therefore this provides some confirmation that this is the condition. We'd have to rely on other instruments to reach that conclusion.
Mm-hmm.
Okay. Thank you, Dr. Tringone. We're running out of time, so there was one other question that we will respond to you separately in terms of the audio CD. But thank you, everybody, for attending. As you can see here, we do have an upcoming revision for the MACI. If you're interested in participating to collect data for this revision, feel free to email us at the email address listed there or give us a call. We're happy to answer any questions that you have. Again, thank you, everybody, for attending this webinar, and thank you, Dr. Maccow and Dr. Tringone, for all your insights.
Thank you.